Okay, well, good morning, everyone, and welcome to this session, which I will be delivering. Oh, okay, sorry about that. There was a flashing screen. Great. Good morning, everyone, and welcome to this session that I will be delivering on a topic that we've called person-centered value-based healthcare. I'm Thomas Kelly, and I run an organisation called Sprink. And I'll tell you a little bit more about Sprink in a moment. Prior to doing this, which I've done since 2019, I was the National Clinical Advisor for Value-Based Healthcare as part of Sally's team in Wales. And prior to that, for 5 years, I led the work of ICHOM outside of North America, based in London. And prior to that, I was a junior hospital doctor at the John Radcliffe Hospital in Oxford. So on to this topic then, person-centered value-based healthcare. So if we go to the next slide, Gareth. Okay, I just wanted to tell you a tiny bit about my the organisation that I'm responsible for. We have it split into two global centres. One which looks at this topic of person-centered value-based healthcare, which of course is the topic for today's discussion. The other which looks at food and the development of healthy food environments in healthcare systems, and how we can ensure that the food that's served largely actually to staff and visitors is healthy, sustainable and ethically produced. Okay, next slide. So the background to this work, looking at person-centered value-based healthcare, is, I think, a question that's relevant to all of us, which is why do we work in healthcare? Now, I've selected 5 organisations that you can see here: the NHS, the Royal Melbourne Hospital in Australia, Charité Hospital in Berlin, the Massachusetts General Hospital in Boston, and so that industry is also represented, the European Federation of Pharmaceutical Industries and Associations. And when you look at the vision and missions of all of these organisations, what are some of the key things that they say? And I put some of those there. So with the NHS, there is this highlighting, as I think we're probably all very familiar with, that patients come first, we value every person, and we aim to improve people's lives. Very similar, really, when you look at the Royal Melbourne Hospital, committed to working with you, meaning the patient, carers, and the wider community. Charité has a real focus on understanding people as individuals. MGH in Boston, guided by the needs of our patients. And FBS, which is typical, I think, of many of the pharmaceutical companies and indeed medical technology companies, again, the overarching thing being that we want to improve people's lives. And I think then we have to ask the question, based on what we are doing today, what does it actually mean to understand the extent to which we have improved the lives of individual people? So if we go to the next slide. So I've left this in. We can't play it now because there's a challenge with the link, but hopefully if you have the slides afterwards, you'll be able to watch it. It's a short video, and I'll just summarise the essence of it. It's an end-of-life conversation led actually by Atul Gawande in Boston, and it's a lady with cancer who is describing what she wants to do during the final few months of her life. And her explicit wish is that she wants to be able to take her grandchildren to Disney World. And that's then what the team focus on trying to make happen. Now, I think that type of conversation at the end of life is something that I think is recognised as being important. But I think we then have to further our question. If the first question was, why are we working in healthcare? If the second question is, how do we truly understand if we really have achieved what matters to individual people and that we've improved their lives? The third question then, I think, is how do we learn from what is happening in this end-of-life arena and think about how we extend that out across the rest of healthcare? So if we go to the next slide. And of course, what has advanced our thinking tremendously, I think, in this area is what we're all very familiar with, which is value-based healthcare. And value-based healthcare typically has focused on trying to understand those outcomes that matter to people and trying to standardize the way we capture those outcomes and then to systematically collect them and then to use that data to support decision making in the clinic or in the encounter with a healthcare professional, as well as benchmarking quality improvement, where the focus has largely been. And of course, we know that the systematic measurement of cost is also an important part of the value equation, and perhaps is a little bit behind the progress that has generally been made around measuring outcomes, but nevertheless is important. Okay, next slide. But based on what I said at the start, and based on what we've just had as that overview of value-based healthcare, is it really the case that value-based healthcare is ensuring that we are working towards what really matters to individual people? Because that's what we say, but is it really? And if we are not doing that, and I actually believe we're not, I think we're on the way to doing it, but I think we're not at all there at the moment. If we're not, then are we at risk of believing that we're creating value, but in actual fact, we're destroying value? And that's, again, I think, a question for you to reflect on. Next slide. Now, value-based healthcare was, I think, largely coined as a term around about 2006, when Michael Porter and Elizabeth Teisberg's book came out. And as I say, I think has been responsible for a tremendous progression in how we think about performance measurement within our healthcare systems. But prior to value-based healthcare, around about 2001, we really got this increase in our focus on what at the time was patient-centered healthcare. And that, again, as quite a lot of these things do, came out of the US via the Institute of Medicine's report, Crossing the Quality Chasm, where Don Berwick, actually, who was part of the committee writing that, said this, that patient-centered healthcare is the experience of transparency, individualization, recognition, respect, dignity, and choice to the extent the informed individual patient desires it in all matters, without exception, related to one's person, circumstances, and relationships in healthcare. Now, that I think has moved on too, as we try to increasingly talk about people rather than patients, and that is the development of the concept of person-centered healthcare, where it's more about an individual, as I say, with an illness, rather than trying to conjure up this sick role. And I think what we typically have seen with patient-centered healthcare is that's often been around functional aspects of health, like reducing the burden of disease. Person-centered healthcare is about trying to understand truly what people value in their lives. And so often you see in the literature a distinction between a functional life in patient-centered healthcare and a meaningful life in person-centered healthcare. Okay, next slide, Gareth, please. And so I think when we're analysing the contribution that person-centered healthcare and patient-centered healthcare has had in terms of how we think about designing and delivering our healthcare systems, I think there's a question to ask, which is, have we really been able to systematically measure performance via this person-centered approach? And have we also been able to effectively compare how we're doing between peers? And I think the answer to that is no, not really. So again, just reflect on that. And if we go to the next slide. And of course, when we think about these two concepts, what we also have to do in all healthcare systems, and particularly ours in the NHS, is to think about how we ensure that the resource that we have is equitably allocated across our different populations. And it's very clear that we can't do everything that everybody wants in the person-centered category, and equally there isn't a limitless amount that we can spend in order to continually improve outcomes. So we have to somehow balance all of these things together. So our view has been, if we go to the next slide, that where there is an opportunity for us to think about is, as we think about the tremendous contributions that value-based healthcare, person-centered healthcare and population equity have made, they have typically sat in isolation. And so our view, and you'll see what R is in a moment, is that we need to bring these things closer together. It's not about inventing something new, it's about trying to ensure that we get to the centre of this Venn diagram where we have person-centred healthcare, value-based healthcare and population equity working well together. And that is why we have termed it person-centred value-based healthcare, to respect the contributions of the person-centred healthcare community, the value-based healthcare community and population equity central to both of those. Now, and I must credit Sally for this diagram. It's something we both worked on for years, and Sally came up with picturing it in this way. On to the next slide. Thanks, Gareth. So that was our hypothesis, if you like, that we thought this could be a good thing to do. So the first thing we needed to do was to find out, do other people share this view, and if they do, how can we look into it and try and figure out a way to actually do this? So on the next slide, what you see here is a table, and we tried to bring together an international group of 20 people across geographies and stakeholder groups. As you know, I don't think there's anything particularly revolutionary about this as a process, as often you see with expert type panels. But I think we were able to bring some really good people who've got tremendous experience in many different areas. So we had the head of the Danish healthcare system, for instance, Adam Wolf, who the ex-Minister of Health from the Netherlands, Zoe from the Department of Health in Victoria, Australia, and Carol Dipp, who leads the International Alliance of Patient Organisations, and many others. So they all felt, actually, well, we also think there is something for us to look at here and to see if there's a way for us to move this concept forwards. In addition to these people, next slide please, Gareth. We also were very conscious that we didn't want to run the risk of getting, if we were going to try and develop a concept that would have potentially significant implications for how healthcare systems operate around the world, we didn't want to have the risk of perceived or indeed actual bias from industry. But we were also very conscious that industry have a tremendous amount to contribute, and we also didn't want to lose that too. And so what we thought was best was that we had FPIA chairing the industry advisory panel, Thomas Alvin, together with John Wilkinson, who had just retired from being the head of devices at the MHRA in the UK. And they were part of our main group, which I showed you on the previous slide. And they chaired this panel, this industry advisory panel, to get ideas from different companies, which could then be fed into the overall process. But the companies couldn't determine what was included. It was for our overall community, the one on the previous slide, to take all decisions as to whether they wanted to include recommendations from the industry panel or not. And you can see the range of companies that were part of this on the slide. Next slide, please, Gareth. So we went through a structured method, which has just finished, just last 6 weeks ago, starting in July 2020, going through a series of steps, which is essentially were about what are in the first part here up till about January earlier this year, what are the questions that we want to ask? What are our key research questions? And what do we think could be a good structure for trying to lay this out in a report? We were then we were able to do a systematic literature review and some input from one-to-one discussion with the different members of our community, and that led to a formal report, which then the industry advisory panel reviewed and gave their suggestions, and then the overall community reviewed and decided what changes needed to be made. And there were a number of changes that we did need to make. And then we launched the report at a couple of global launch events at the end of September, and now we're just preparing the manuscript. And what I'll tell you at the end is we're just launching a global centre, which I told you at the start actually, which will help drive this work forwards as we move on. In terms of sponsorship, and I want to acknowledge 4 organisations that gave grants to this. So one was the Institute for Evidence-Based Health at the University of Lisbon. The other was the Health Standards Organisation and Accreditation Canada, which is an international accreditation non-profit body in Canada, or based in Canada. Leiden University Medical Centre, and the research for this was carried out by one of Leiden's PhD students, Martha Kidane-Mehren, supervised by Anne Stiglbout, her supervisor, a part of our team, and FPA2, the European Federation of Pharmaceutical Industries and Associations. And also to say that Nicola Bedlington co-chaired the panel here with Sally, as 2 very respected international leaders. It was very important, we felt, that Nicola and Sally were able to chair the community of experts as they were their peers, and I think that worked very well. Okay, on to the next slide. So what did we find, and what were our ideas coming out of this? So we felt that a recognised way of dividing up our healthcare systems, actually largely from health economics, this sort of structure, but useful for this, I think, is micro, meso, and macro. And what I'm going to do now is talk you through some of our very concrete things that we think we need to focus on, and indeed that the Global Centre is focusing on to try and help do this and to demonstrate the importance of it. So first of all, the micro level. Now, next slide, please, Gareth. We think it is extremely important to not simply tell people these are the outcomes that we're going to capture, and these are the outcomes that matter to you. Because how do we know that? And the answer is we don't. And we also don't think it's a good idea because things change in people's lives, and particularly with chronic illness. So there has to be a question: how do we advance that forwards, building on the tremendous work that has taken place so far? And we think there is a very simple way of doing that conceptually. It's potentially quite complicated to implement, but conceptually it's straightforward, and that is we need to understand people's goals and preferences. And we need to link those goals and preferences up to the outcomes that we're capturing. Now, there is no limit on somebody's ambition and what their goals are and what they want to achieve. Where preferences are concerned, we should understand people's preferences, but of course understand that we might not always be able to meet every single preference that somebody has. It's also very important that we don't just focus on the outcome, that we have to understand as part of the goals and preferences what is important from a process of care perspective and from a structure of care perspective. Because what was very clear as part of our work is that the process can be every bit as important as the outcome in terms of what matters to a person. And they may well sometimes, or we may well, depending on what our personal circumstances are, decide that a certain process is preferable, even though it might achieve a worse outcome. And that, of course, is the decision of each of us as human beings. It's important, of course, as we do this, that when we're looking at goals and preferences, that they're structured and that they're recorded, and that's done in a systematic way. As I say, in the next yellow box here, we then need to link those up to the outcomes we capture. And that's where it comes in that we can build on the work that we've done, because it's really important. We think, and I personally think, that we do need standardized outcomes. And so if somebody does want to survive, and that is important for them at that stage in their life, well, we do want a standardized definition for survival. But if they don't want to survive, we need to understand that so that we don't focus on survival, even though it's not what somebody wants to achieve. And then it is for clinicians and people who are receiving care to work together to determine how they can best use the resources that are available to achieve those goals and preferences that matter to people. And as I say, we should also link those to processes and structures. And all of this is, I think, underpinned by shared decision making, and it's of course reviewed on a continual basis. And I had a conversation a couple of weeks ago with Phil Clare, and I don't know if Phil's listening to this, but Phil made me think about the shared decision making as a concept, and I personally think it's extremely important. But there is a question there. It implies that it's a shared decision between the clinician and the patient or the person. And we have to watch that too, I think, because ultimately the person that is responsible for deciding what their goals and preferences are is the individual, and that's what we have to listen to. Okay, next slide. And by the way, of course, this is all very much in evolution, so I'm sure there's things that I'll be saying here that require a lot of discussion, but these are our ideas, and as I say, what we're now hoping to work on to try and help use some of this in practice. So at the meso level, and the meso level meaning the service, the pathway type of level, we have to make sure, and I think this isn't emphasised as part of value-based healthcare, but is emphasised as part of person-centred healthcare, hence the need to bring the two together, that the pathways and services that we design are of course person-centred and responsive to the needs of a particular population. And we should, again, I don't think we need to reinvent here. There are very established techniques for getting that understanding across a population in terms of what matters to people from a service design perspective, and we need to be very systematic about doing that. I read a thing in the Financial Times today about the discussion. The article went is not about in-person care versus remote, it's about how we best use medical advances and technological advances to create primary care that is responsive to people. I think that that partly misses the point in my view. I think we have to make sure that we understand what's important to populations. Of course, we have to lead to and try and move things forwards, but we have to be thinking about what is it that is also important, in my view, to the populations that we serve. Resources that we have, and as we start to allocate resource at that population level, it's very clear that we cannot buy a single thing for every single person. We can't design a process that matches the preferences of every single person. I don't think that's possible to do. So we have to, of course, design things at a more aggregate level that respond to the needs of populations, and then it is at the micro level, clinical teams and others to decide how they can best use those processes, structures, and resources to meet those goals and preferences. And of course, then what has bothered me for years, actually, when we start aggregating standardized data at this meso level, at the moment, I don't think we can, well, I know we can't say that we know that what we're aggregating is reflective of what matters to people. Some of it, of course, is, but some of it will not be. And so by trying to do this approach, we think that will help ensure that the data we're collecting, we have the context, and therefore we will be able to understand if survival or if quality of life or if some other outcome actually is reflective, when we aggregate that, of what individual people want. And similarly, as we aggregate process and structure data, that should also do a similar thing. And of course, it should also, as we know through the work you're doing and we've done for years, that also helps to helps us to understand why certain outcomes are or are not being achieved. Okay, on to the next slide. So then we go to the macro level, which is typically across an entire population. And I think here, again, we have to learn from what person-centered healthcare says, which is that, and I think this does happen, but I don't think it happens as systematically as it should, which is that patient advocacy groups then should be, again, systematically involved with the design and development of health system policy and strategy. The resource allocation decisions, again, at that level, also need to be guided by input from people and indeed patient advocacy groups, because again, that needs to be taken at an aggregate level, that type of decision. And when it comes to health technology assessment, there's a lot of work to do here, and hope that our centre can contribute to some of the research in this, how we make sure that health technology assessment also focuses on those outcomes that matter most to people. There's a challenge there around comparative effectiveness research and how we do that, but it's very important. And I think where life science companies are concerned, we need to make sure, in my view, that we, if we are incentivizing life science companies by the real world value that is achieved, we need to make sure that we are confident that that value is reflective again as to what matters to an individual. So those companies need to be partners in the system in helping to make sure that their products, medicines, technologies, whatever, and anything else are targeted at the goals, preferences, and therefore outcomes, processes, and structures that reflect what matter to those individuals. And it's not enough for us to simply incentivize based on survival, as I keep coming back to that, as it's a straightforward example, if that is not what matters to a particular person. Okay, next slide, Gareth, please. And this is an example of what it simplistically could look like, and this is for breast cancer. And we developed this with Christabel Saunders, and Christabel's actually, she's just moved, I think, to be a professor of surgical oncology at the Royal Melbourne Hospital. She was at the University of Western Australia, and actually prior to that, she was at UCLH in London. That you can see the goals on the left-hand side of this. That what you might imagine some breast cancer people might want. I want to live, you see there, point number one, a length of life as close to normal for someone who has not had cancer. So we can capture their overall survival from the ICHOM data set. I would suggest. I want my breast, point number two, reconstruction to look normal in my bra. Well, the breast Q should enable us to do that as a prom. I want to continue to work, point number three, full-time in my present busy job without debilitating side effects. And the EORTC QLQC 30, although perhaps not ideal, but it's maybe as good as we've got for now, could help with that. And a similar thing you could imagine then as we link that to the processes and structures. Okay, next slide. So there are, of course, unanswered questions in a lot of this. I mean, I am convinced that this is the right way to go, as my personal philosophical viewpoint is that we have to make sure that we empower individuals to take care of themselves as far as possible without, of course, harming others. And that's hopefully what this also helps to do. But there are risks with that, and that's where our further research agenda hopefully helps to contribute to some of this, and hopefully many of you will also, hopefully it resonates with you, and you'll also be thinking and contributing to this type of discussion. But not least, how do we make sure that when we do focus on these types of goals and preferences, that the people who have a strong voice in society already, that they are not further strengthened, and the people that have a weak voice are not further weakened? How do we manage that, and how do we manage our own inbuilt biases that potentially could potentially negatively impact on as we go down this type of route? I don't think that's a reason not to do it. It's a reason, I think, for further research to make sure that we tackle those potential types of problems. So what does this mean for different stakeholder groups? I think for people receiving care, I think they have the option, and I don't think people don't have to do this, but it's important, I think, that people have the option to define their goals and preferences, and I think hopefully are encouraged to do that. And then hopefully are able to work with their healthcare teams to determine then how to achieve those goals and preferences within that envelope of resources that are available. Where healthcare systems are concerned, it does mean then that we can truly say that we're putting people, their goals and their preferences at the centre of decision making and design, which I think is what we all want to do, and I hope this is a way to help at least do that. For where companies are concerned, from the research and development angle, it's very important, which many of them are starting to do, to focus on the outcomes, of course, that matter to people as endpoints in their research. But I think it's then important that companies do partner with healthcare systems, as I was saying just earlier, to ensure that the products they make are then properly targeted at the right people, focused on achieving their goals. Payers at this stage, I think, should be incentivizing systems and companies to focus on goals and preferences. I'm not so sure we should necessarily be paying based on outcomes yet, but I think we should be incentivizing this type of approach. Where governments are concerned, I think there is an argument to have a national policy and appropriate programs of education to help embed this type of thinking. Okay, next slide. So some thoughts about moving on, and with many of you being from the NHS in Wales, I think it's essential to continue the work around capturing outcomes systematically, using standardised data sets, focusing on capturing costs, and I don't think this should distract from that. I think that's very important. But where we have very mature parts of the system that are, doing the outcome, potentially the cost capture well, and it's embedded, I think this could be an opportunity to then be an idea for you, at least, as to what the next step might be, and that could be then around the how to start systematically capturing goals and preferences. I think we do need a far greater systematic focus around people's input into the design of pathways and services, and I think we need, as we increasingly think about partnering with pharmaceutical and medical technology companies, I think we need to ensure that they are also aligned with not just giving these to everybody, but really just the same as they target their medicines according to an individual's genetic profile. Increasingly, we should also be targeting medicines and technologies according to an individual's goal and preference profile as well. Okay, next slide. So I just wanted to tell you this one, and this is what we are going to do, and we will have a number of national level launch events over the course of 2022, and they will be in a number of different countries, just to further stimulate the discussion around this. We are setting up a global implementation program, which will start in roughly April, and the aim of that is a range of different organisations from around the world, so that we can start doing some of this, and then hope. And I must say, I mean, of course, we're not the only ones to be talking about this. There are examples in the literature where people are doing this. So it's not, it's not it is there. It's just not widespread. So we want to be able to do that and to hopefully share then some of the learning that comes out of it. We will have a virtual education program which will focus in, and that we'll have the detail of that in January, and the first round will start in September, and that will focus in on some very specific aspects of this, both knowledge but also skills, and we've got the funding now in place to do this. There will be a range of further research, again very much focused in on some of the things we've discussed. There's the standard sort of networking type of activity, which I think is extremely important in these things, and there are a range of other services that go along the side. So that is what we've done. There are thoughts. These are the next steps, and it would be great to hear your reflections. Thanks very much.
So that was a fantastic presentation, and really interesting and thought-provoking, Thomas. So thanks very much for that. We've had a couple of questions come in for you. The first of them is, how does sense of place and geography affect the person's healthcare?
Yes, thank you very much. I saw that, and I mean, I think this plays into the part of the rationale for pretty much everything I've been saying, actually, because it is clear that the things that matter to each of us as people are very much influenced by our background, our culture. Now, is it supposed to be flashing? I think.
Yeah,
okay.
Go ahead. Yeah, everything's fine.
Exactly. Great. It was for some reason flashing green on my screen. Yeah, so I think based on our background, based on our own cultures that we're in, based on the countries where we might live, and also of course the regions of those countries, they shape our outlook, they shape our perspective, and therefore they shape what we might want from healthcare in terms of the process that we might want, and of course the outcomes that we might also want, and that of course. We have to reflect that, I think, in how we're measuring success, which is why I think part of the reason we do have to think about goals and preferences. But we also have to reflect that in the way we design services, which is why I do think we have to have a person-centered approach to design that has to be responsive to those needs, as well as the ideas, preferences, goals of different populations. Clearly there's a limit, as I say, and we can't be doing one thing for every single individual, but I think we can try and develop this from a process perspective so that it is more responsive to what individual segments of populations want. I hope that's helpful.
That's lovely, thank you. And another question that we've had sent in via email is, how do we generate more evidence of the impact of shared decision making on outcomes? Yeah,
well, I think we have to be more systematic about doing it. So I think, my background is as I say, as a hospital doctor, and I think maybe quite a lot of us do. When we have time to do this, there is always an element of shared decision, or often I think an element of shared decision making, but I'm not quite convinced that we are all brilliant at doing it. I can certainly say, it's not that long ago, that I had absolutely no training in how to go about doing that sort of shared decision making type of consultation. So I think the first thing we need to do is we need to do more of it, and that's partly why we want to do this virtual education program, so that people can access some of this easily if they're interested. And then I think it's potentially possible, just as we, in terms of any form of comparative research, for us to be able to see in those systems where we have been able to have a significant impact in terms of the amount of shared decision making that's taking place, what is the impact of that compared to those comparable healthcare systems where there is, where that is less widespread. My suspicion is what we might well end up seeing is that we will get worse outcomes, because I think we have this focus on certain things, 5-year survival in cancer, and we're trying constantly to get that up. I'm not convinced that that is always the best thing for us to be doing. And so by doing some of this, we might actually see that 5-year survival drops, but that of course is not necessarily a bad thing. Yeah, I hope that is a useful reflection.
That's fantastic. That's great. Thanks, Tom. Another question is, PROMs are very useful tools, but there are other measures like activation measures, health literacy measures, holistic assessments and experience measures that also support person-centered care. How do we employ the right tool at the right time that avoids survey burden or drowning in data?
No, and I think that's a fantastic question, and I think that's part of our discussion, really, which is if we are agreed on this principle of where we might be able to evolve how we measure performance in a way, or how we measure healthcare systems, then of course there is a question then, as you're saying, which is what are the most appropriate tools and metrics that we need in order to do that. I think we know that outcomes are important, and as you say, PROMs are part of that. We know that some form of process is important. We know that the structure is important, but clearly there are other things, and that I think is part of a discussion to say, well, what do we think within our different healthcare systems? I think where experience is concerned, experience is interesting because, again, that is something that is highly variable potentially from individual to individual in terms of what they want. So somebody might want extremely good food, somebody might not be at all interested in that, and they instead want to make sure that they've got free car parking, somebody else. And again, you can't design these things so that they meet every single person's preference. And so what we had felt, and again, this isn't necessarily right, what I'm going to say, it's just a view, is that experience is more of a core condition of a healthcare system. Like a value in a way of an organisation, what is the patient experience that we as a system prioritise? And that, of course, should be informed by input from the wider population through these established methodologies so that we can do something that people want. We're not just telling people. And I personally think that's probably the right way to go. And then, of course, we could have measurement that's measuring the extent to which we achieve that. But my final point, and I'm waffling a little bit here, but is that I agree with you. Of course, in all of this, we have to balance not achieving survey fatigue.
That's lovely, thank you. And another question. Just by collecting and making data available to clinicians will not automatically translate into shared decision making, or at least not for all. How do we grow patients and clinical teams' skills and confidence to use the information to support its application?
Yeah, great, thank you. I mean, as in my belief always has been, and I think, and very definitely still is, that people working in our healthcare systems, the vast majority of us want to get the best outcomes for people. I mean, that's why I think that's why pretty much all of us are here. And so that's a very positive thing, of course, because that then means we have to support making that happen. And I think parts of the way that we can do that is by doing things that resonate well with the different stakeholders. And I do think that what resonates with people, patients, I don't particularly want to call people patients, but just so we know who I'm referring to, that I don't think any of us particularly want to be told what matters to us. I think it's a personal thing. So I think it's important that people are asked that, and I think that leads to engagement from patients, in my view. And then if that leads to engagement from patients, then when we start to measure the data, it contributes, I think, to greater levels of completion of the different surveys. And I think then if we have greater engagement from patients, that supports us having greater engagement from clinicians. And I do think that clinicians, I think, are very much focused on trying to help their patients. I mean, although I say that we haven't all been trained in shared decision making, the importance of that clinician-patient encounter, that I think is ingrained in all of us, whether doctors, nurses, physios, whatever our professional background, social workers, we all really believe in the importance of that relationship. And so I think if we can help ensure that the data that we're capturing supports that type of interaction, which I think with the goals, with the outcomes, also understanding the process, it does support that, and I think that helps with engagement. And then as we progress up the system to the meso and macro levels, I think that it helps, because then when we have good quality data that is meaningful, that's well structured, that's presented in a good way, which I know the national team and indeed the value-based healthcare teams across Wales are working on, that I think is all helpful in engagement and utilisation of the data. Again, a bit waffly, but I hope you got something out of that.
Thank you. At the moment, there's just one last question. So unless there are any others to come in, so I'd encourage anyone who has any further questions to enter them into the chat while you're answering this one. Is how or where does one join these future discussions and keep up with progress, please? And that's from Angie.
Yes, and thank you, Angie. We're just everything will go live actually next week. We're just finalising a few specific details, and we'll email out to it'll go on the various different social media channels, as well as to the mailing lists that we've got. That is it's not of course just about Wales list, but more broadly. And there will be things in that enable you to join up and as you ask, hopefully be part of it. The reason for trying to have this global centre was precisely for this type of question, because it was very clear we were getting this question a lot, and there wasn't a sort of formal way of saying, well, you can be part of something. So that's what this global centre is trying to achieve. We've got the funding, as I've said, so that gives it some stability, and so hopefully when you see some of this communication next week, it'll give you some ideas for how to engage. Thanks.
Lovely, thanks, Tom. And we have had one more question in while you were chatting, and that is an anonymous question. Do you see more patient-centred care actually increasing unwarranted variation in care, as in the opposite to value-based healthcare?
Yeah, thanks. I mean, I think it depends what you mean by unwarranted. In my view, if it's leading to more variation, but it's actually what people want, then that's warranted variation. The concern I personally have is that we're reducing what we believe to be unwarranted variation, but actually we're doing that blindly in a way because we're not understanding what people want. So we almost have a perception of reducing unwarranted variation, but the reality potentially is quite different. So I think back to the very start there, I think what we have to do is we have to keep the standardized data because that enables us to compare, it enables us to learn and improve, but we have to link it up with the goals and the preferences of individual people. That gives us the context, and we have to not be afraid if people start making choices, and again we need to understand exactly how to do this, but that if they start making choices that go against what we might have traditionally thought of in healthcare. And the Atul Gawande books, I think his books are very good, but the video I was going to refer to, I think is a really good one to watch because it shows oncologists and all of these things that they can do, much of which has had a tremendous contribution to people's lives. But actually, there's quite a lot which has had a very negative contribution because there has been this blind pursuit for survival, even though it makes people, in some cases, of course, not all cases, but feel terrible. It doesn't actually improve their life at all. It's just trying to keep them going and going and going. And that's not what we should be doing in many cases. And so it helps to reinforce the message. We have to listen to what people want, and we have to then make sure that the way we behave as healthcare systems is responsive to that as far as possible. I hope that answers your question.
That's lovely, thanks, Tom. We haven't had any further questions in, so I would just like to say thanks ever so much for your time today. It's been a really interesting and thought-provoking session. We have shared the link to the video that you wanted to show on the chat so that everyone will be able to see that. And thank you very much again for your time.
Yeah, my pleasure. Thank you very much. Thanks for the invitation and thanks for the questions. And I hope it's given you some food for thought.